Very good morning to y'all, and let me first thank the GIS for inviting us. And I'm representing the Sri Lanka College of Cardiology and from the beautiful island of Sri Lanka. So this is a case of a left main coronary artery bifurcation stenting with the mini crush technique, which we had to engage the left main with two separate catheters. And I'm a senior registrar in cardiology attached to the National Institute of Cardiology at the National Hospital of Sri Lanka, Colombo. So it's a 53-year-old male patient with a history of diabetes, hypertension, and dyslipidemia. Had a history of anterior ST elevated myocardial infarction in March 2025. And that time the patient was thrombolyzed as the PCI facilities were not available at the local setting. And then there was satisfactory resolution. And the patient was on optimal medical therapy for heart failure. And he continued to have the class 2 symptoms and shortness of breath, and therefore was referred for the PCI center for revascularization. So he had a BMI of 24, pulse, blood pressure, and the examination was unremarkable. Basic investigations were normal, and the echocardiogram EF was 45% with anterior anteroseptal and apical hyperkinesia compatible with old MI, and the muscle mass was preserved. So we did the angiogram, and as you can see here, so there is a bifurcation lesion with the left main, about 70% lesion distally, and with the Medina 111 with the large circumflex coronary artery with the calcified LAD, and RC images are not displayed, and the total syntax score was 32. And we've discussed with the patient, and this was a 53-year-old patient, and he refused CABG. And therefore, we offered him the complex PCI. So we engaged the left main radially with the 7 French catheter, XP3, and the LAD was wired with a Renato wire, and the circ was wired with Asaicion blue guide wire, and was planned to do the procedure. And we've ballooned the circumflex with the Mosaic 2512 balloon, and then we ballooned the LAD where we noted there was a calcified lesion proximally, which was difficult to be opened up initially, but was subsequently opened up with a 2512 high pressure balloon. And then we noted we wanted to further optimize the lesion, and then we wanted to balloon it with a further high pressure balloon, but it was difficult for us to pass the balloon, and then we had to use a guide extension catheter to pass the pre-dilatation balloons. And with the guide extension, we were able to pass it, the 312 balloon, and was inflated to 14 ATM. And subsequently, we actually were able to deploy the stent through the guide extension. However, we were planning to go for a mini crush technique, and then we had to put the crush balloon to the circumflex, where we found the difficulty that we were not able to pass the balloon through the same guide catheter. So therefore, the challenge was noted, and to face it, what we did was we got the femoral access, and then we engaged the left main with a JL guide catheter, and with that we wired the circumflex separately, and through that we passed the crush balloon to the circumflex. And with the crush balloon in the circumflex, then we stented the LAD neostium with 2 struts of the stent within the left main, and then we inflated the stent, and subsequently after deployment of the stent, the wire was removed, and then the stent struts were crushed with the 4512 balloon in the circumflex. And after this, we rewired the LAD, and then initial kissing was done. And from here onwards, the procedure was completely conducted through the femoral access. And then we subsequently opened the struts of the LAD stent, and then we post-dilated the stent and then stented the left main to circumflex with the science prime stent 3538. And then we did the pot. Again, we took the wire out because there were 2 layers of metal. And after the first pot, we recrossed and balloon kissing was done. And then we post-dilated the circumflex stent. And then an unexpected result was noted at the edge of the stent. There was a dissection, which we had to cover again with the separate stent. And then a repeat kissing was done. And then the final pot was performed. And after that, these were the final results. And yeah. So this case highlighted the importance of a rare case where we had to use 2 catheters to engage the left main so that we can pass equipment and get additional support. And so similar techniques have been used before. And so as this is a complex PCI and we need to have the skilled in a resource poor setting. And one thing was that intracoronary imaging, which if it was available for us at that point, would have been helpful in the initial calcium assessment as well as the detection of complications such as the post-procedural edge dissections that we've noted at the end of our procedure using the cine images. However, with resource-limited settings like that in Sri Lanka, we'll have to continue with these challenges and to perform complex cases. Thank you.